in terms of imaging, and I moved it from being up at the top to under this category during cancer treatment, cardiac safety surveillance. Now, I don't know if everybody agrees with that general subtitle there, but so we can talk about that, or again, this section about the following general principles are recommended for medical imaging. We got through the first bullet, and that's the one that's highlighted. Highly reproducible, quantitative, volumetric, non-irradiating imaging with quality control is preferred. So, in the document itself, obviously we need to put in some provisos, which include that, you know, right now 3D echo and MRI would be the most quantitative. That type of expertise is not going to be available everywhere, and so we would just have to put that type of discussion in the document. So I don't know if everybody agrees with that statement, since that was at the very end of our talk last time. Do you have any comments there?
This is Bonnie. I think my only major comment is, as you know, Dan, Juan Carlos is putting together an ASD type document, and I just think that ideally, and I think it depends upon, of course, what the group consensus is, but they should not be too disparate from what he's saying. It sends mixed messages if we're all saying, if all the different groups are saying different things. I do think that basically, though, is in line with what the document will be saying, to use 3D when possible and also strain when possible.
Right. Well, so we're not saying anything in conflict to that, as far as I can tell.
Yeah.
You know what? What Bonnie said is, Bonnie just hit it on the head. Take the word currently out and put ideally.
Yeah, ideally.
Okay.
But sorry, again,
sorry.
Are you going to leave that there in that part of the document, or are you going to put it later, the highlighted sentence in yellow, are you going to put that in the body of the report?
In the body.
Okay.
I think that for our recommendation, it's going to be higher level than that. It's going to say what it says right there, which is highly reproducible, quantitative, volumetric, blah, blah. That's the recommendation.
So sometimes, yeah, what I've seen done too is people just put these as qualifying statements, but if it's going in the body, that's fine.
Yeah, I think that, the problem is that to have a concise recommendation, you can't really introduce just a little bit. If you're gonna talk about 3D echo or something, then you're gonna have to talk about the comparison between 2D and 3D and strain and MRI. You're gonna have to put all of it in there. So you need to develop that discussion. It's going to be longer than a concise statement.
Would you consider putting in front of the word quality good, quality control, or do you think it's implied?
We touched this. This was right at the very end last week. I don't know if you remember, but we were trying to think of how can we put in the phrase quality control now.
Right.
I don't know, acceptable, good, or whether you need to put another word there or not.
Yeah, I was just curious what people felt. I mean, one could think it's implied, but it may not add really much, actually.
Does Bonnie or Joe or Charlie have any thought about that?
And one thing I was thinking about on this is, in terms of all of these things, I'm not familiar with 3D echo, but there's still going to be a certain amount of variability, intra-reader or inter-reader variability. Should we mention that when we're making these decisions, that someone should actually look at the images themselves rather than just the reports? Because I find even when people are working really hard, you can go back and look at 2 or 3 echoes, and I'm still in the 2D echo world principally, and people will do their best, but if you look at 2 or 3 echoes, the images serially, you'll get a different impression about what's going on than if you look at the pieces of paper.
Yeah, I mean, I agree with that, and I think we should discuss that. It should be in this whole context of 2D versus 3D and MRI and contrast, et cetera, et cetera. We should put in there that images should be reviewed for accurate measurement quality, essentially, or something along that line.
I think that was the beauty of the MUGA. I mean, the oncologists didn't know that the background subtraction done by the tech determined the EF, but they at least got a number.
Right, but then they just took the number for whatever it was. I mean, those of us who did the MUGAs know that it's just like really is exactly like an echo. You trace the margins, and depends on how you feel like tracing the margins.
Yeah, it's really this is a really serious point, Dan. I saw a young woman with breast cancer 2 weeks ago who clinically had nothing from a cardiac standpoint, and she was at another institution. She had an echo. They told her EF was 40%, and she couldn't get TCH because of it, and she ended up coming. Actually, they told her she couldn't be treated, and she came here for a second opinion, and she had a normal. I mean, there was no reason that she should have had an EF that wasn't normal. And I got the echo, and her EF is 65%. So somebody looked at a report that was misinterpreted, and she was going to not get treatment.
Yeah, I know. I think that's a huge deal, and I think that
so we would have.
But I think that I don't think that can't be in our recommendation per se. I mean, it can be in the discussion, which it should be.
Well, I think we should mention, and the majority of these people are going to be assessed with 2D echo, I would think, at least for the next, the intermediate future, and then we should make a note that one of the limitations of 2D echo is variability between interpreters, and that the cardio-oncologist, the cardiologist taking responsibility for management of the patient should view the echoes to be sure that their opinion about the variation or abnormality is what they're based it on. I mean, I tell a lot of people, they see the echo reports, and I just look at them and say, well, there's variation here, and I'm going to take responsibility for continuing your treatment. And this is what the EF is for me.
Yeah, and I mean, I think that goes to, the EF is actually just a test. So, I mean, the clinical context is more important, and that's what I think it's really imperative that the physicians, both the oncologists and the cardiologists, actually input important information and not rely solely on a test. That is, whether you talk about a white count or an EF or a BNP value, they're just tests. They are not the whole story. So,
unfortunately, people look at the test and don't think it is the whole story. We may be outliers here, Dan.
Well, can I just comment? Sorry, can I comment, Dan? So,
sure.
I think there is the problem. Is that I think in the past, because of the lack of communication between the two, oncologists and cardiologists, people were making decisions based solely on that number.
Oh, absolutely. And I mean, that's if there's any fight that I want to take on, it's that one. that it's one thing you can argue about how the test is done, and the quality control, and the images, and whatever. We certainly talk a lot about that, but in the end, it's just the test, and we really need to factor in the rest of the story. So how about the next bullet? So I think that what I will just say about this section that's highlighted is that we will have this statement in the document, and it will be built out with many of the other things that have just been said. So we'll
I was thinking of proposing one edit to that statement, though. I don't know what everyone else thinks, but ideally quantitative 2D and 3D echo and MRI. Because, like as Charlie's saying, not every, I mean, for the places that don't have that may not have 3D capability as of yet, yes, they may work to get that within their lab, but then in the interim, they should still do a quantitative 2D tracing and not just a qualitative eyeball.
Okay. Yeah, I mean, I think it's just much more likely that, it's far more likely that 2D echo is what's going to be done for the next decade. Okay, and then the next bullet, the one that says
non-controversial.
In an individual patient, same study modality. Okay. Do we think that we have level of evidence A for that statement or not?
I'm not sure that anybody's ever done it really is, there's not trial evidence for that.
Well, there actually is. I mean,
it's practice.
Edith Perez published a paper in 2004 with, one of the major breast cancer studies, and they had serial measurements of EF, and they had in some patients it was, they had an echo and a follow-up echo, and in other patients they had a MUGA and then a follow-up echo, and vice versa. And anyway, she showed a significant amount of variability just in that test, and that was in JCO like in 2004, and Edith Perez was the first author. So and that was a randomized study, in terms of breast cancer treatment. So I think that there's pretty good evidence out there.
Okay.
So, I mean, I think, in my opinion, it would be either between a B or an A.
I agree.
Okay. And then the last bullet, serial global longitudinal strain imaging should be considered when available for baseline and serial EF determinations. Are we okay with that statement?
Yep.
Yeah.
Okay. So a very minor point would be, is global strain really part of serial EF determinations? Those are two different things, actually. I don't know if that subtlety needs to come out in a recommendation.
Cardiac function evaluations, I don't know.
Why not just available for baseline and serial and subsequent studies?
What about saying should be used as adjunctive assessment of LV performance? That way, we're not talking about it being in serial LVEF determinations, but we're using it as an element of determining LV performance or toxicity, development toxicity.
Okay, so we'll go with function. How about that?
Systolic.
Serial systolic LV function. Okay. So, and then what level of evidence would we assign that one?
Well, I think it has to be a B.
Yeah.
Okay. Because there have been a couple of papers recently about using that, but they're not major randomized studies. They're small cohort studies. Okay. Does any of the people have a vote as to which section you want to tackle? So far we got general principles done, and we have this little itty-bitty section about echo imaging. Does anybody have a preference where we tackle
let's
next?
just take them in order, Dan.
Okay, so then I'm going to go back here. Pre-cancer therapy routine assessments. Do we think that is an appropriate title for this section?
Cardiovascular risk assessment, maybe? Pre-cancer therapy cardiovascular risk assessment? I don't know.
Sure.
Yeah, I think in anything writing the word routine is a problem.
Okay. All right, so then let's pick the first one. I'm sure this will engender a little discussion. So, for patients undergoing potentially cardiotoxic cancer therapy, should have baseline biomarkers.
Just take the word for out to begin with.
Does everybody on this call agree with that statement?
Yes.
I agree.
We got agreement on that statement? That's awesome. I love it.
And
Yeah,
not an echo?
Coming. I guess.
Yeah, that's part of what we just did, but this is specifically talking about before cancer therapy cardiovascular risk assessments. So
I agree, there was echo in there somewhere. It should be.
okay.
Do you want to say anything about what those biomarkers should be?
Exactly, that was what I was going to say. So you need to say what they should be.
Okay, so what should they be?
Homocysteine level.
Troponin, right?
No, we're not going to say that.
So what are you going to do?
Well, so
BNP, troponin?
yeah, for sure everybody will.
BNP, troponin I, huh?
Should we do a highly sensitive troponin I or just troponin I?
I don't think you should or need to specify I or T, because like at Penn we only have T, and that's the platform that we use, and and I think it's whatever platform is clinically available.
Good.
See, Dr. Cardinale used the ultra-sensitive troponin I in her research.
No, it wasn't actually ultra-sensitive. Yeah.
Ultrasensitive is still a research platform, though, right?
Yeah.
For the most
Yeah.
part. So that's not.
I think if we're trying to not delay therapy needlessly, the grosser ones probably would be okay to get started with.
So do you want to particularly name N-terminal proBNP?
Yeah.
Yeah, yeah.
BNP or
And BNP or NT-proBNP.
Okay. Anything other than BNP, N-terminal, or troponin?
I don't think so.
Okay.
So let me ask a question. As a baseline, I mean, we don't generally, as baseline means before treatment, right?
Yeah.
Yeah, so how many people have circulating troponin?
I know.
As a baseline, I'm not sure that there's much cost.
Well, I think that there's reasonably good evidence, and Bonnie contributed to this, that you have a significant change, and that's an important finding. So in order to have a significant change, you have to have a baseline assessment. So if you have a 100% rise in your troponin, that could be an important
Yeah, the problem
finding.
is our troponins come back less than come back as less than 0.01, and I'm not sure that you get a good. If it's detected, then later, then it probably is different than the baseline.
Well, I just think that that's the current that's what's happening in Penn at this moment. But tomorrow, your lab may decide to change their troponin assay to one of these high sensitivity ones. So I think that it's out there for sure. The values that are
Yeah, I'm not
specific
arguing
values.
about getting them with treatment, but just asking about the baseline.
Well, I guess my only point about that would be is that you don't know if there's a significant change unless you measure it. So, all right. Well, what kind of level of evidence do we think we have for that one?
I also think B. I mean, my only other comment here, actually, and then maybe, but is that should it be worded more like the strain and the 3D section? I know that not everyone on the call agrees with that, but should it be worded with that, should be strongly considered, or, because I don't as a clinical practice, I mean, Joe, we're trying to get 3D and strain incorporated in our clinical labs, but, if I see a patient who's, let's say, 28 and about to start anthracyclines or TCH, and she has no cardiovascular disease, no risk factors, no nothing, I wouldn't measure BNP and troponin, but I don't know, I don't know. Maybe that's wrong. Maybe I should be. I know that we're doing research in this field and we're trying to figure things out, but I don't.
Well, I mean, I think that
over a higher risk population.
I mean, so in a heart failure population, would you agree that a BNP is valuable?
Yes, in a heart
for
failure
outpatient
population.
management? I mean, I think that there's.
Yes. Yes.
I mean, but that statement right there, I can't even get agreement with every one of my heart failure partners that statement is right. But you have major studies that have shown that BNP is valuable in that context. So I'm not sure you're going to get 100% agreement anytime. And I just think that in order to know if there's a significant change, you have to measure it at baseline.
Again, I don't have any problem with BNP, Jim.
Well, again, I think troponin is the same in that everybody, and I mean, just from a cardiology oncology point of view, how many times have we ended up diagnosing amyloid because we measured troponin? I mean, that has happened 10 times in the last year for sure. So I think that it is a marker to pursue.
I mean, I definitely use the markers at baseline in the patients who have cardiovascular risk factors, hypertension, etc. I will use them, but that's why I'm just saying that the wording maybe should strongly, be strongly considered, instead. Because if I saw a 28-year-old, let's say,
so then
I might not.
So then, how do we? What should the wording say? Patients undergoing potentially cardiotoxic cancer therapy should. Okay. We might have to reverse the sentence to say baseline cardiac biomarkers should be strongly considered in patients.
Yeah.
Okay.
Are we okay with that?
Yeah.
Yeah.
Or you could say may be helpful, may be considered. That way, Bonnie's.
Then we start sounding like radiologists.
I'm okay with it strongly be. I'm okay.
Yeah, we start sounding like radiologists. please consider maybe if you think it's okay.
Well, that would be one of my worst nightmares, to sound like a radiologist, so I'll withdraw the comment.
Dan, it's okay because, like in Bonnie's 28-year-old person, that the likelihood that troponin, that they're going to have amyloid or troponin is elevated is it's clinical judgment there. It still leaves room for people to make a decision.
Yeah.
Okay.
Hello, I was just going to make a comment that the new Theranos testing at Walgreens is offering the troponin I for $677, and the BNP is $24. Okay, in terms
Yeah, and I mean, that's so true because, you know, how many goddamn BNPs can you do for one echo or MRI?
Right.
Yeah,
I mean,
it's $24 at
you can
Walgreens.
do several hundred.
Right, it's $24 at Walgreens for the BNP, and $6.77 for the troponin I, and that's going to be nationally. Right now, it's in California and Phoenix, but it's going to go national.
Is that's seriously true?
Yes, that's one drop of blood. That's a company called Theranos that Elizabeth Holmes started, who dropped out of Stanford at 19. And she started this company that's based on one drop of blood. That's all you need is one drop of blood.
Okay, so are we okay with this statement? Baseline cardiac biomarkers, specifically BNP or N-terminal proBNP, troponin, should strongly be considered in patients undergoing potentially cardiotoxic cancer therapy.
Yes.
We okay with that? Okay, level of evidence B. All right, good. There's something. All right, so since the time is up,
let's finish the box, this little box.
Okay. I'm not sure that's going to happen, but all right. So for patients undergoing mediastinal radiation, secondary prevention targets is recommended. So that statement is not good. But
what exactly does that mean? Can you explain that?
Yeah.
I don't know what that means exactly, but
so I think why not say that mediastinal radiation is a risk factor for atherosclerosis and risk factor modification according to guidelines should be considered. I think that's more than considered. Mediastinal radiation is a risk factor for atherosclerosis, for accelerated atherosclerosis.
Well, I mean, it's valve disease. I mean, those European radiation guidelines are pretty expansive about what they're worried about.
What do those say? I haven't ever actually looked at them.
Well, but they're the valve disease. You know, there's valvular disease mentioned in there. I mean, I think if we're going to just mention the cardiac targets or victims of mediastinal radiation, you know, valve pericardium. But I don't know what just in terms of secondary prevention. Maybe it would just be atherosclerosis. That would be the only thing that could be prevented of the risk factors of the targets.
How about some kind of parameter for follow-up? And then is there anything we want to get for a baseline and which patients?
So I was just trying to think of, so from the paper that Susan Darby published in the beginning of 2013, and then I'm taking it from what Charlie said about the European radiation document, that what people are calling for is, assessment and treatment of cardiac risk factors.
Right.
And I mean, I would certainly agree with that plan, but how we would say that in a concise recommendation, I'm not sure. So what I was typing in there was just that general thought. I don't know if that makes sense to people. Mediastinal radiation is a major risk factor for cardiovascular disease, and cardiac risk factors should be optimally managed during that.
Managed period. I think that's okay.
optimally managed during that treatment modality?
Yeah, I think lifelong.
Yeah, it's more, mediastinal radiation is really years out. I mean,
That's what I was going to say. Isn't it years out that you?
so I mean that would be it's a major lifetime risk factor for cardiovascular disease.
Right, but the people that had cardiac risk factors at the time of treatment, had a higher propensity of disease. That's basically what the recent data has shown. So it implies that we should treat that optimally, at the current time. So, I don't know if we don't have any kind of randomized study that says you should do that. We just have the general idea that we should.
Maybe we could say mediastinal radiation is a major risk factor for cardiovascular disease that increases the impetus for managing cardiac risk factors during treatment. Because it does increases the benefit or increases your consideration to treat risk factors, because there's another one, because it's an extra one that's significant.
And it probably should be going in after.
Okay, I don't know if this sentence sounds okay. We might want to think about this one a little bit. But so mediastinal radiation is a major risk factor for cardiovascular disease, and this emphasizes the need to manage cardiac risk factors optimally.
To optimize cardiac risk factors.
To optimize.
Period. Cardiac risk factors. Period. Maybe.
During this treatment.
I don't think you have to say, Dan, during the treatment, because
Yeah.
if it's a lifetime risk, shouldn't you just be optimizing them all the time?
Yes.
Yeah.
How about modify rather than
Make it-
optimize? Optimize just sounds kind of funny.
Need to
Modify, attenuate.
How about that? Is a major risk factor for cardiovascular disease, and this emphasizes the need to modify cardiac risk factors throughout treatment.
And after treatment, right?
Mm-hmm. I'd agree.
Yeah, and after. Okay. So we're gonna. What kind of level of evidence would we assign that? A B or a C?
Well, would you say a B? I know, was some Sarah Darby's paper, right? I can't remember. I mean, there was some evidence.
And Greg Armstrong did a paper in JCO about a couple of months ago. And most of those were childhood survivors that got radiation treatment, and ones that they had a higher incidence of risk factors are the ones that had a bigger problem. But,
B is okay.
okay. All right. Well, good. So again, I would say we made some nice progress there. So we will go with 30 minutes every Thursday. Except for February 13th when we'll present a case, and keep working at this. I think made some good progress and actually have quite a bit of important statements there. And I think that once we agree on what we're going to say, then we can modify the document to correspond or provide evidence for these recommendations. So, all right. Well, thank you very much. We'll send this out.
Thanks,
and
Charlie,
think about
Bonnie.
what you want to tackle going forward.
Thanks, everybody. Bonnie, Charlie, Greg,
Okay.
Joe. Appreciate you coming. Bonnie, I heard you had a recent trip to Salt Lake City.
Oh, yeah. I met your daughter, right?
My daughter said hi. Yeah. She was.
Yeah, she's terrific.
Thought you gave a pretty good talk, and she enjoyed meeting with you.
Oh, great. Great.
So thanks
Okay.
so much
Yeah.
for being
Thanks,
part.
guys.
All right, thanks a lot.
Bye-bye.
Thank you.
Thanks. Bye.
Goodbye. Thanks.
Bye.
Bye. Bye, Dan.